Well, I think it's obvious why it's worth it. I mean, you see people that maybe are homeless because of having issues with using opiates, and then as you become part of the interdisciplinary team, you see patients becoming success stories. But it does take time, and it is a learning process. You learn something from every patient. So
we start with primary care, then we have added its behavioral health and substance abuse, and integrating that with our primary care. The thing that I say as a physician, it's really a disease, and we're here to treat that disease just like we do any other disease.
I think it's so important in our community because we're losing generations of people to substance abuse, and we're seeing the effects in these children that are being raised in these families where substance abuse is occurring. And I want to be part of stopping that cycle and to offer hope to our community, to help improve our workforce, to improve our educational system, all of those things that are important to have a good, healthy community. This is part of it. We have to have recovery for those individuals that thinks there's no hope.
I can't imagine, after caring for a lot of folks and treating them with MAT, I can't imagine doing that without the medical portion. Each visit isn't just prescribing MAT. A lot of it is, dealing with hypertension, diabetes, wound care. It's amazing how many medical problems these people have that weren't being taken care of in the past. And so most of our visits are not just for MAT. Most of them are really looking at anxiety and depression, or looking at other medical issues that they're having. So I'm thankful that we have that holistic model, that we can care for both medical and their addiction.
It is part of primary care because it affects everything else. It's not a problem that's on an island. If they have substance abuse disorder, then they also have mental health issues. Then they need to be in counseling. They need to be, they probably are going to have some other issues like smoking that we need to address. Maybe COPD that comes with smoking. We also need to address that. A lot of them have chronic pain that started this problem. So I think it's actually the best place for it, because then they're getting the whole, they're getting primary care. We're treating everything.
Well, I think it's nice to have all of it at one place, period. It makes it easier for the patient to navigate. A lot of times when a person is active in addiction, they're not going to the medical doctor. They're not getting dental care. They're not getting just regular treatment. So if we have that here for them and they're already engaging with us, they're more likely going to engage with the doctor too to get those primary care needs met, like an annual physical. Something I might take for granted because I have easy access to it, they probably have neglected for a long time. If we have it here in the office, it's easier for them to obtain.
From the primary care side, we want to look at their overall health, and we want to evaluate how their blood pressure is doing. If they're at risk of something such as hepatitis C or HIV, we want to make sure that we get them screened for that. So there's a lot of other things that we try to deal with from a primary care side versus medication-assisted treatment side.
We had a residential unit at the Fort Thomas location for about 2 years or so, maybe 1.5 years to 2 years, and it was phenomenal. So we had a peer support specialist go over there along with a case manager twice a week for the whole day, and then we also had a therapist over at the same time, and the medical doc would go over twice a week also. And what happened, the difference was these were all patients that were on long-term IV antibiotics, so they were there for 6 to 8 weeks, and the vast majority of them, 90%, were opioid users. Or substance use disorder or opioid use disorder. And when we first got there, the AMA rate was really high, and they would refer them to us for treatment as an outpatient, and hardly any of them ever came. And they'd stay in their rooms, and at night they would be up and their sleep patterns were off, and it just wasn't a good experience for the patients. And after we were there for about 6 months, they were coming out for groups, they were eating lunch at a regular time. The rate of transfer over to our offices, for follow-up improved significantly, and the whole morale improved. So I've been doing it for a while, and it's been very reinforcing. You know, I think what happens is when you see people do well, that makes you want to continue doing this.